Anyway, you can see the screen, yeah? That's it. That's better now. Okay,
yes,
so
sir. We can see the full screen now. Yeah.
thank you very much. Thank you. So first of all, a big thank you to organizing committee for inviting me, and also obviously to Rajiv Kaushal for making the initial invitation possible. My role, my purpose for this talk is to describe the role of PDL1 in lung cancer. This was a title which was recommended by Rajiv, and I've done my best to provide a talk which may be of helpful to the participants, who I believe are mostly molecular biologists and molecular scientists and also molecular pathologists. So this may give you another angle to the story that Rajiv has so nicely opened with. Basically, I'd like to describe the immunobiology, immuno-oncology and immunopathology of PDL1, basically because it's a multifaceted molecule. It's from an immunobiological angle, it is basically an immune checkpoint inhibitor. From an immuno-oncological perspective, it acts as a very good drug target, an actionable drug target. And finally, as an immunopathological factor, it acts as a very good biomarker to allow selection of patients, a predictive biomarker, basically. So those are the three issues I'd like to cover in my presentation. Obviously, the target of my talk is non-small cell lung cancer, which obviously includes lung adenocarcinoma and lung squamous cell carcinoma. And most of the treatment that's given is given to advanced NSCLC, so stage 3B onwards up to stage 4. So, so far that's where we have reached in terms of the drug therapy. As a checkpoint inhibitor, PDL1 is just one of several checkpoint inhibitors, basically developed physiologically to inhibit cytotoxic T cell action. This is sort of done through, in case of PDL1, through its binding to its receptor on cytotoxic T cell, which is the PD1 receptor. And this is highlighted in the red rings, as you can see in this. As you can see, there are many other checkpoint inhibitors which are all operating at different points. Basically, the PDL1 is working at the what we call checkpoint 2 level. Checkpoint 2 level inhibition takes place in peripheral tissue, where the actual effector cytotoxic T cells are released from the lymphoid organs to mostly combat virally infected cells. But this purpose also, they also serve the purpose of killing tumor cells, which also express foreign-like antigens, what we may refer to as neoantigens. So any tissue or within the body which expresses foreign antigens or foreign-like antigens, the cytotoxic T cells are there to destroy them. However, in doing so, there may be a bystander effect on the normal tissue. And if this particular function of CTL is not controlled or regulated, there's a risk of bystander effect, which could amount to autoimmunity and could be quite damaging to the body. So the PDL1 system and the other checkpoint inhibitors are evolved to protect the body against this bystander effect and focus the action of the cytotoxic T cells against invading infected cells, or in this also case, in our case, tumor cells, which are obviously injurious to the body. The important thing about PDL1 is that it as a inhibitor, it operates with full functionality, but produces less side effects, as I'll discuss when it is blocked. So this blocking of the blocker mechanism, which I'll talk to you in a minute about, its immuno-oncological role. Basically, the tumor cells produce lots of immune suppressory factors, but they also can express PDL1 directly. And this expression of PDL1 by tumor cells and also immune cells in the vicinity, what we call tumor microenvironment, can interact with CD8, which are expressing the PD1 receptor. And this interaction leads to the either apoptotic cell death of CD8 positive T cells, or they become energized. So either way, the main endpoint is that there is not sufficient CD8 population available to destroy the tumor cells. There are obviously other mechanisms, T regulatory mechanisms and so on, which are also activated by PD-L1 route. So the final result is immune escape of the tumor cells. And this ends up manifesting the tumor in the body. So immuno-oncological mechanism that I just described has become one of the hallmarks of cancer development. The good thing about PD-L1, unlike other inhibitors, is that it is expressed in such a way that we can detect it immunohistologically. And the whole purpose of my talk is based on that principle, that we can detect the PD-L1 expression on tumor cells as well as immune cells. And that gives us an early idea of whether this mechanism is operating as one of the mechanisms through which the tumor is escaping the immune system surveillance. Also, PD-L1 and PD-1 itself are eminently targetable by antibody drugs, which are shown in this illustration. And several drugs have been produced by several pharmaceutical companies with great effect. And these drugs have now become virtually a standard treatment practice. They're very expensive, but they work extremely well, very, very specifically. And so this diagram shows the power of PD-L1 as an immuno-oncological target. So essentially, the original work was done against melanoma, which obviously produced some dramatic result. But with respect to the lung cancer, this particular picture that I've taken from early trial, phase 1 trial, showed how powerfully this drug actually eradicated very large lung cancer. And the other thing was that the response was proportionate to the amount of PD-L1 expressed by the tumor. So this is obviously the full data of the trial when it was completed. And you can see that the higher the level of PD-L1 expression by the tumor cells, the greater is the response. So this is a direct proportionality. And that gives a very powerful sort of use of this marker. It's a biomarker for selecting patients for the treatment. And basically, if I can just put it like this, let me just see. I think I need to move out my... So you can see on the right-hand side, the highest level, which are well over 75%, up to 100% tumors expressing the actual PD-L1. You can see the response rate can be as high as 35%, which is way above the 9% response that you'd get normally with the chemotherapeutic regime, in this case, docetaxel. Let me just move on. Oops, now what's happened? I think I lost my... Oops. Okay, let's go back this way then. Somehow they've done something to stop my screen moving. Let's see if I can. Okay, that may be the reason. I think there are. Okay, so main thing to add, in addition to that diagram that I just showed you, is that the level of expression is such that you don't need to count in the intensity of expression. So any intensity of expression, however weak, all you got to do is count the number of tumor cells which are expressing PD-L1, whether it's expressing at 1+, 2+, 3+ level. So intensity doesn't matter. And this diagram also shows you the optimal cut point, which is 50%, above which the actual response rate is quite dramatically and highly significant and reproducible. Now, using this approach, lots of work has been done now, and this is one of the latest diagram figures, I should say, available to say how many different drugs and at which point in the actual phase of treatment PD-L1 antibody therapy is being given. It's powerful enough to be given as a monotherapy, even in a first-line setting. And of course, it is very useful even in a second-line setting under certain circumstances. The main thing is that the level of expression will determine which mode you use, the anti-PDL therapy or anti-PD-1 therapy. And basically, in a first-line therapy, the higher the level of expression of PD-L1, the better chance and makes sense rationally to give it. Whilst in a second-line therapy, even TPS of as little as 1% or more could be useful. So these are obviously based on drug trial data, which are now firmly approved by FDA and other regulatory bodies. So end result is that we want to try to develop an index of PD-L1 expression, and that for that the tumor proportion score has been introduced, and basically it's a very simple index. Basically, you count all the PD-L1 positive tumor cells present in a biopsy, and you divide it by all the viable tumor cells positive for PD-L1 and also the ones who are not positive for PD-L1. So you basically develop this ratio and multiply it by 100 to provide the TPS, which is expressed as a percentage expression of PD-L1 in that particular biopsy. And then you can determine whether it's over 50% or 1% and or less than 1%. Coming to now with that point in view, I will now briefly describe the immunopathological role of PD-L1. Basically, as Raju has very aptly described the importance of pathology's involvement at this stage to ensure that the limited amount of tissue that's available is very carefully utilized. And so obviously before you start anywhere, you need to obviously confirm the diagnosis histologically, and if you need immunohistochemistry, of course, that will be added at this stage. And then the next thing is to give priority to molecular testing to see if there are any actionable molecular targets. And it's been recognized by the immuno-oncologists that they take priority over the immuno-oncological treatment because these targetable, actionable molecular changes are very well treatable with the drugs that are available, and they are also with less toxicity than the actual immuno-oncological treatment. So there are a number of reasons. Plus, they're probably relatively cheaper than the immuno-oncological treatment. So overall, the strategy is that you do your diagnosis, then do your molecular testing. If there are no actionable targets at molecular level, then you take the immuno-oncological treatment on board for the next step. Basically, you at that stage get the biopsy, staining with PD-L1, and determine the TPS. And basically, doing this particular type of counting, you need to take into account that only membrane staining of the tumor cells is included. It doesn't matter whether it's partial or complete. That part is all right. And at any intensity above 1+, as I mentioned earlier, is that you need to include in your counting. You must obviously exclude any immune cell staining from the scoring because that can be a tricky situation. Sometimes macrophages can look just like tumor cells. And you must not include any cytoplasmically staining cells also. Basically, you must also use a validated assay. This is very, very important. There are many assays available, and they can create quite a confusion in terms of the accuracy and reproducibility. So ideally, you should use a clinically validated assay, what they call clinical trial assay, or a validated assay which is lab developed but is validated against the clinical trial assay. You have to make sure that the analytical performance and all the other things that are needed are operating in the right direction optimally, so to allow you to actually produce a result which can be meaningfully counted and sort of taken further for the development of score. And it's Raju quite rightly said that if you make any errors at this level, then you'll be in the same position as garbage in, garbage out type of situation, which will waste everybody's resources. So the details are basically that you have to restrict accounting to membranous staining, however weak, as long as it's 1+ and above. You use a specified approach on the microscope. Times 20 objective lens setting is what you use as your standardization of your counting procedure. And you try to exclude any cytoplasmic positive cells, however strongly they may be staining. And few other things are included in that kind of criteria, which I can't go into detail at the moment. At the end of the day, you end up categorizing your score as either being less than 1% or anything between 1 to 49% is referred to as low expression, and finally, high expression would be above 50%. In practice, it's been realized that roughly 1/3 cases are negative, basically, or less than 1%. 1/3 cases are roughly in the low expression category, and 1/3 cases are in the high expression category. So this allows pathologists to know that their practice is in line with demographic data available worldwide. Having done this in the report, you would point out what kind of biopsy on which you've done the counting, whether you use sections or cell blocks, and you must have a minimum of 100 viable tumor cells to allow the counting to take place. You must also specify which assay you use, which clone you use, because each of these assays and clones will have a different threshold requirement to make it positive or negative, and whether you use clinical trial assay or lab developed assay which was validated. And finally, you record the score as positive, negative according to a threshold, either 1% threshold or 50% threshold. You may optionally indicate the therapy indication that the data with this particular case may suffice for first-line treatment with monotherapy and so on. But this is not required. This could be done at the tumor board meeting between the pathologist and oncologist. So very much to summarize now, immunobiologically, what I've done is to show you the immune checkpoint 2 inhibition mechanism, which relates to PD-L1 at the checkpoint 2 level. I've previously described the immuno-oncological value of PD-L1 as part of a targeted it's a target for immunotherapy. And finally, I've talked very briefly about its use as a predictive biomarker for immuno-oncological treatment targeted at PD-1 or PD-L1. So thank you for your attention, and I'll be happy to take questions at this stage or during the panel discussion. So thank you for your attention.